Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hey, my favorite learners, welcome back. Today is a fun one because I've got Tanner and Cole from the Core Anesthesia joining me, and we're diving into a topic every anesthesia provider needs to truly understand: malignant hyperthermia. We're breaking it down from the molecular level all the way to real-life recognition and management, with plenty of stories and practical pearls along the way. If you've ever wondered what's actually happening inside the muscle cell during MH, or how to stay calm when things get wild in the OR, this episode is for you. Let's jump in. Hello, my favorite learners, and welcome back to another podcast episode. We are talking all things malignant hyperthermia today with Cole and Tanner from Core Anesthesia, which is an amazing company business of these two educators and clinicians, podcasters in the CRNA community, which is amazing to see our profession be used in this way. So like I said, we're talking about malignant hyperthermia today, but I'd like to open it up to hear a little bit more about what Cole and Tanner do and how they started their business. So boys, go ahead and share that with us.
Yeah, first of all, thank you so much for having us on today. I love what you're doing. This is just an amazing initiative. We're just blessed to be a part of it. So thank you for inviting us. For those that don't know, Tanner and I, we graduated from our anesthesia program in 2021, and we met in school. Obviously, when we started school 3 years before that, became study partners, and really we realized that there was a gap in just the audio-based education available to us while we spent so much time driving back and forth to campus and clinical sites, etc. And so we basically decided, well, hey, like let's just record our own study conversations that we're doing, because at the time we realized you forget so much content within a week after taking an exam. You just move on to the next topic, and you're just getting flooded with all this content and information. It's like, how are we going to remember this when we take boards 3 years from now? And so we decided to record our study conversations that we were having between ourselves while we drove to campus. And our classmates found out about it, and they really wanted us to send it. And Tanner was the tech guy. I was never the tech guy, but he was like, it's so annoying to have to send this large audio file through email to all these people. And so we ended up just putting it on Spotify, on Google Podcasts, etc. And it just blew up. We never expected it to turn into more than what it really was. Again, it's just a way for us to get through school and to study. And now it's grown to, we have a little over 3/4 of the students in the nation that use us to go through the different curriculum for anesthesia. And we have a full encompassing curriculum now. We ended up creating an app called Core Anesthesia, which provides CEUs for CRNAs, quiz questions, videos. I mean, you name it. We pretty much covered everything that we learned during our anesthesia program. And again, we never thought it would grow to what it is, so we're so blessed to see how far it's gone, and that the amount of impact that it's actually had on this community has just been so enriching for us.
Oh, thanks for having us. This is like, I geek out a little bit on this kind of stuff because I remember when we were in school, like Cole and I always talk about us messaging people that we saw on social media, because we're like, once it started getting a little traction, we're seeing these people on social media and we're like, oh, let's message them. Maybe they'll repost our stuff. And we've seen your stuff all over social media, and we feel like we already know you. I mean, I think we met briefly in Nashville. It's fun for us now to like be in these conversations and be able to have these collaborations that we never dreamed we'd have, especially when we just started out with Course. Thanks for having us on. This is going to be a blast.
And I'm happy to have you guys. It's an honor. I actually had a student last week or 2 weeks ago. I was doing my opioid lecture, and he was like, oh, methadone, how do you use it? And I was like, honestly, I never have. And he's like, oh, well, I listened to the Core Anesthesia podcast, and he sent me the link to your guys'
Awesome.
with, I think Richard Wilson was on it. So I got to go back and listen to that one to see how you guys use and talked about methadone to add that to my lecture. So it's nice, like you said, to have this big community of CRNAs, one, giving recognition to what we do as nurse anesthesia providers, and encourage ICU nurses to become one of us is my core value, but no pun intended. So today, like I said, we're going to talk about malignant hyperthermia. And I actually saw MH, and my students are probably rolling their eyes because it's all I do is talk about this like cool scenario. So I may mention that later on. But we're going to start talking at like the molecular level, right? So can you kind of talk about like the pathophysiology that goes behind MH and patients that are susceptible to malignant hyperthermia, and what makes them susceptible?
Yeah, I feel like this is something that we had flagged all across our ICU when I worked in the ICU. It's all these signs like malignant hyperthermia, what do you do when it happens, like patients on the vent, etc. And I just had this very naive understanding about it when I was in the ICU. Just, oh, it's somebody that spikes a really high fever related to something. Like I didn't really understand it. But as I got into CRNA school, then I really learned the background of what is happening on the molecular level from this, and it makes a lot more sense if you understand what is happening. It really just then maps out logically how you would treat it, what you would do to stop it, etc. So what it is, it's really a pharmacogenetic disorder of the skeletal muscle. So if you think about, we often talk about like a nerve signal going down the nerve, it passes the synapse and it opens up, it binds to the nicotinic receptor on the skeletal muscle, and it goes through this whole pathway. If you remember from undergrad, we've studied all this stuff, and it releases calcium inside the cell to cause a contraction. Well, what is releasing that calcium? Specifically, it's a receptor called the ryanodine receptor, an RYR1 receptor. And it's basically located, if you have the membrane of the cell, it dips into this T tubule that drops into the cell and causes that receptor to open, which then causes the sarcoplasmic reticulum to open, and you have all the calcium flood out, which causes a contraction. So, and specifically with malignant hyperthermia, it's when you have an altered version of this ryanodine receptor, or it's less commonly known as CACNA1S, which is obviously why we all call it ryanodine receptor. It's way easier to pronounce, but it's when this is dysfunctional, so to speak. And when you have this occur, now you can think about it. If you have the signal cross, from the acetylcholine cross that synapse, bind to the muscle cell, it causes that contraction stimuli to go all the way down the membrane, down that T tubule, and then it opens this receptor. Calcium's released. Well, now the problem is you can't close that receptor appropriately. You can't close the sarcoplasmic reticulum. So now you just have this uncontrolled release of calcium that's just spilling out into the cell, which causes then everything logically makes sense after you know that, because now you just have this sustained muscle contraction, which is going to be just chewing through and burning up all your ATP. So you're going to have ATP consumption just out the roof, because now you're just contracting everywhere. And as a result, you have all this metabolism. So you're hypermetabolic, you're causing increased heat production because of this, which is why we get the malignant hyperthermia name, which we'll talk about more later. But then if you can think about it, if the cell is just squeezing down and contracting so much, it starts to break down the structural components of the muscle cell itself. And so you have rhabdomyolysis that occurs as well. So really, if you understand that, it's just a long, uncontrolled contraction of these cells because you can't close the ryanodine receptor and close the sarcoplasmic reticulum. Now you just have this uncontrollable contraction that's just releasing all of this metabolic activity.
I think one of the big things that we try to talk about a lot on our episodes is like, you can memorize all this stuff, sure, but like going through CRNA school, there's gonna be so much material that's coming at you. It's impossible to just memorize everything and do well. So you need to understand concepts, and if you can understand concepts, then you can get to the solutions here. So if you can memorize this list of, okay, we're going to see hyperthermia, we're going to see ATP consumption, we're going to see rhabdo, hypermetabolism, all those things, but you need to understand that it's a calcium issue, but then also we have an ATP issue where we're having ATP being used to try to pump the calcium back into the sarcoplasmic reticulum, and also we're having ATP used just with the cross bridge that's happening with the muscle contraction. So now you got to think about, you're flipping over with all this oxygen consumption, you're moving to an anaerobic state. And so now we're also seeing lactic acid production. And so when you start to think about all the different things that are cascading from that initial process, now you can understand why you might have hemoglobin in the urine. You can understand why we're needing to treat potassium because of the shifts here with cell damage, also with calcium, why we're needing to look out for hypercalcemia, and also the calcium shifts. And so there's a lot of things here that you can just memorize, but you need to understand, okay, the issue here is the ryanodine receptor. At the same time, we're constantly trying to pump that calcium back into the SR, and it's just a never-ending cycle unless we do something to fix it. So obviously we'll be treating symptoms. We need to treat the root cause, But I just like to encourage you, if you're listening to this and you're like, oh, that's a lot to remember, try not to just remember everything. Try to understand the actual process, and then understanding that structure, you'll be able to connect the dots a lot more easily, test boards, all those types of things.
Yeah. And honestly, I love how you mentioned that about just memorization, because that is, again, something I reiterate to my students is like, if you just think about it logically, you can understand the really nitty gritty molecular things so much easier instead of just memorizing. I call it data dumping, right? You like memorize. And then the day after the test, you couldn't tell me about the sarcoplasmic reticulum, like anything about it. And so I love how Cole had mentioned that if you think about that sustained muscle contraction, what would happen if you had sustained muscle contraction? Just think of that logically. You could probably make a list of the signs and symptoms of MH just based on that fact alone. So I really love how you guys mentioned that. And obviously, when I had my scenario clinically, we talked about how, or I researched actually, that you have these triggers, and we'll talk about the triggers later. You have the triggers that cause this cascade of events that happen. But actually, in some patients, they may have had, we always ask, have you had a history of problems with anesthesia? And this is what we're looking for, right? But actually, you can have patients that have had an anesthetic before and had no MH reaction, and then have an MH reaction later on down the road. That was something as a clinician I didn't know was possible. But keep that in the back of your mind, that just because somebody hasn't had an MH reaction to a trigger, they could in the future. So we're always very rare, but we're keeping our ears perked at all times, like Tanner said, to catch it and to treat it. And that's when our intervention comes in to help patients. So again, I love the clinical aspect of it because that's my background and my strength as a former clinical coordinator. Let's talk about that recognition. So in the operating room, what are we going to see in terms of the early signs of MH in the OR?
Yeah, just from the name of it, I was always like, well, if they're hyperthermic, then obviously, we're going to be looking at MH. And there's even been times practicing where you're like, man, this patient's temperature is really high. Like, I wonder if I'm like getting into some MH stuff or, and really we need to understand that's going to be a very late sign in terms of identifying if a patient is experiencing MH. Like you mentioned, Chloe, I love the idea of just think about like going for, a massive workout, or you've had massive muscle contractions. Like, just think about like, what are we going to see from that kind of a picture? So you'll see tachycardia. You're going to see masseter muscle rigidity. That's especially with succinylcholine. That's something that you're going to see very early. This is a little tricky for me. I remember the first time I gave sucks, I was like, I saw the fasciculations and I was like, here we go. First day on the job, I've given sucks and here we go. I'm 2 for 2 on MH patients. And you need to understand this is very different than just the fasciculations that you're going to see. This is a sustained muscle rigidity. And a lot of times, if it's truly happening, you'll see that actually go out into the trunk and to the extremities as well. So you'll get a generalized muscle rigidity as well. The big thing that you need to think about with this, and this will be the first thing that you should be paying attention to, is unexplained rise in end tidal CO2. Again, this makes sense. Think about us, running a marathon or doing a big exercise. You're going to be generating a lot of CO2. Our muscles are contracting. We're having this prolonged contraction. And so we're going to have byproducts that are coming off of this reaction. And so you're going to see this CO2 that's going to be unexplained. It's different when you are doing a laparoscopic procedure and you see a small little bump and you're understanding that some of that CO2 gas is starting to absorb, or maybe you've got someone that for different respiratory issues, and you start to see that CO2 start to creep. This is something where it's very unexplained, and it's going to be pronounced too. You're going to notice like, hey, this CO2 is elevated, and I'm not able to rectify it with changing just vent settings or things like that. So if you see a bump in your CO2, that's going to be, I tell people all the time, like end tidal CO2, if I had no other monitor, end tidal CO2 is what I would live by. It's going to tell you so many things and give you so much information in so many different scenarios. And this is not different. This is, again, where you need to really be thinking about MH when you see that unexplained rise. Other things that you'll see is the mixed metabolic and respiratory acidosis. We talked about, again, when you're understanding why this is happening. So you have respiratory acidosis because of that increased CO2. You're also seeing metabolic acidosis because you're moving into that anaerobic metabolism. And so you're going to have that increase in lactic acid. And so that's simply because the ATP is being used to pump the calcium, or trying to pump the calcium at a rate back into the SR as the ryanodine receptor is staying open and just dumping it out the other side. We talked about this on one of our podcasts, and we likened it to like pouring water in a pitcher that has no base. And it's like the pump is just trying to keep pumping calcium back in, and that there's no base, and the water is just coming right out the other side in that ryanodine receptor. You're going to have a mix there of metabolic and respiratory acidosis. Kalemia, this is when you have breakdown in the cell, and you're going to have potassium start to shift, and so you'll see hyperkalemia. We'll need to address that. And myoglobinuria from the dark colored, you'll see the dark colored urine. Also, this is going to be from the breakdown and getting that myoglobin in the urine. So this is all things that you need to think about, all signs you need to pay attention to. But again, end-tidal CO2, that's where you need to really have those antennas go up and think, okay, what's going on here?
I love that. I loved a lot of the things that you said, and I try not to interrupt because I don't want the audio to go out. So it keeps me from interrupting, which is great. But end-tidal CO2, number one, that is what I tell students too. And I just mentioned it in a podcast I recorded earlier, is that I call it poor man's cardiac output. I mean, end-tidal CO2 is poor man's cardiac output because it tells us so much about everything, respiratory, the cardiopulmonary system in general. So I love how you mentioned that. I love how you mentioned the marathon and comparing it to running. I just ran a 5K turkey trot. Again, no pun intended, cold turkey. The way I couldn't walk for a day. I just feel normal now. And it's been, what day is it? It's been like a long time. Okay. Since Thanksgiving.
You're injecting Dantrolene into your shoulder as you're crossing the finish line.
I needed it, maybe, I don't know, but definitely that rhabdo. I was thinking like, I'm going to go into rhabdo. You hear about people getting admitted after hard workouts for rhabdo. And I'm like, I need to make sure I'm hydrated and all those things. So you don't see that like Pepsi pee, right? That like Pepsi colored urine and down that pathway. So I loved how you mentioned that as well. All that to say, I do also want to mention that clinical scenario that I had, just to mention that in this portion, the early sign truly for them, this was a pediatric patient, first anesthetic, was a climate end-tidal CO2. And as anesthesia providers, we have that front shelf diagnosis, we have the back shelf diagnosis. MH is on our back shelf, okay? Our front shelf is the airway and what's going on. Are we ventilating, right? Are we not ventilating adequately enough? Did we give a lot of narcotics? And now they have the hypercarbia from the narcotics. And again, that ventilation isn't there and that minute ventilation to keep up. And they had an LMA in place and they swapped. That was the first thing they did is they swapped it for an ET tube because maybe they're having a bronchospasm and they could treat it better with the ET tube, even though they were ventilating adequately with the LMA. And so I love how you mentioned that also. And that's what I saw clinically was that rise in end-tidal CO2 was truly the first sign. Because sometimes we wonder if the things that we memorize translate clinically. And I can say I've definitely seen that firsthand. So have you guys seen MH or no?
I pray I never do. I have not up to this point.
That's what I say.
It made me nervous when you said that, when your research said how patients that haven't had it before can have it later. Because like I'm always like, okay, they haven't had any history. I bet I should be good on this one. And it's like, that's actually really good to know because you might take that off of your differential diagnosis if you know they haven't had it with previous anesthetics. But yes, I hope I never experience it.
It's probably super rare too for that.
Yeah, it'd be interesting to know because it's like they can have different levels to it as well from my understanding of that. So it's not like an all or nothing thing, but I did not have it personally. I was in the like hallway when it started. It sounds very similar to what you were talking about, but it was a pediatric patient, first anesthetic, LMA was in, and same sort of thing, like saw the end-tidal CO2. And then the masseter spasm was like when you started being like, ooh, this is like things are coming together here. Like this isn't just ventilation and of course, like you said, you have your front shelf and back shelf and you kind of like, I feel like we kind of talk ourselves out of those back shelf diagnoses until we're very, very sure. And obviously this is such a huge thing that you're like, okay, I want to be sure, but at the same time, you need to be acting quickly and purposefully move through this to make sure that, damage is not done. But so I was second hands on that case. And that was just really interesting to see it all. I feel like when you're second hands on something like that too, you just have different perspective. Like it's not your patient. It's not your experience. You weren't just talking to this family member and all this stuff. You just come in and you just see like the facts as they are, what's happening. It always drove me nuts when like a new CRNA would come in and give me a break for something and they'd be like, oh, bing, 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 bing. Like you missed like all this stuff. And I'm like, how are they seeing this? I've been in this case for 4 hours. And it's just like, you get into kind of this tunnel when you're there. But I think that was just an interesting experience for me to be able to come in and see it kind of secondhand, obviously being very involved with helping out. But yeah, it's that end-tidal CO2 is no joke.
Yeah. And my situation was honestly similar in that I walked in when the crisis was occurring and they had already come to the conclusion of MH. And so again, it's like, we all try not to judge each other as clinicians, but you do walk in and you're like, oh, I actually, not to be the hero, but I had a fresh set of eyes, right? I walked in and I was like, hey, we have a crisis checklist. Like, let's look at it and let's look to see what we've done, what we haven't done, if that's what we think this is, and do everything else. And they had honestly done majority of it. We called MHOS. That was one of the things that we did that we hadn't been initiated yet. But the clinicians felt so guilty that they didn't diagnose it sooner. They're like, I should have known. But the case was short. And the pediatric patient, the temperature started climbing towards the end of the case. That's when they were like, okay, the temp is going up like 0.1, like every 5-10 minutes. It's now starting to climb. We think this is it. Because again, it's not your front shelf. It is definitely your back shelves. I love how you mentioned that. Because walking into a crisis is always better when it's not your crisis. It's always best case scenario. Yeah, let's talk about triggers now. So we talked a lot about like what occurs and the things that happen afterwards, but like, what are the agents that can precipitate malignant hyperthermia?
Anesthesia. Basically it's just like what we're going to do for anesthesia. Like if there's anybody in the hospital that's going to trigger an MH event, it's us as anesthesia providers.
This is one scenario where you can blame us. You can blame us.
Exactly. Not the weather. This is the one thing. So
not the delay, not the anesthesia delay. Okay.
Pretty much the main trigger for malignant hyperthermia is going to be all your volatile anesthetics. So if we're doing an inhalational anesthetic, which unless you're doing like a monitor anesthesia case, so a MAT case, you're pretty much going to be doing volatile anesthetics unless you know that the patient has a history of MH. And so what I mean by volatile anesthetics would be sevoflurane, desflurane, or isoflurane are the three main ones that we would use today. Either of those three are going to be triggering agents for malignant hyperthermia, along with the IV medication succinylcholine, which you may or may not be using for a specific case. I feel like in the last couple of years, especially with Sugammadex coming around, we tend, at least in my area of practice, we tend to shy away from using succinylcholine and more rocuronium. So that is one advantage to that, is we're not using succinylcholine as much, but you very may well be using succinylcholine for a case, and that would also be a triggering agent. But that's it though, just that list. Again, all the volatile anesthetics, so sevoflurane, desflurane, isoflurane, and then the IV medication succinylcholine that we would give, which is our depolarizing neuromuscular blocking agent. So typically we're giving that if we're trying to rapidly intubate somebody through an RSI. But again, now that we have medication to reverse rocuronium so fast, you tend to see clinicians moving more towards using rocuronium, even for a really, really quick intubation. But yeah, that's really it. So not propofol, not ketamine, not opioids, even nitrous oxide, which is another inhalational agent that we use. Some people often confuse that, if that is safe to use or not. That one is safe. It's just the sevo, des, and the isoflurane agents for the volatile anesthetics that would be a triggering agent. So again, those are the only spots that you really see it. As far as I know, we don't use these medications anywhere else in the hospital but in anesthesia. Occasionally, I think the reason we talk about it in the ICU is because you could give succinylcholine if you're trying to rapidly intubate a patient in the ICU. At least in my facility, we didn't really do that as much, but there are ICUs that would potentially be using that. So I think that's why ICUs are pretty aware of this. But otherwise, we're not giving a patient inhalational anesthetics outside of the operating room. So really, when you enter the anesthesia world, this is something that needs to be on your high priority, because you are going to be giving the medication that's going to cause this.
Yeah, I love that. I was going to say something about, I forgot, triggers. I know, I'm interested to see how, is succinylcholine going to be like the halothane of our anesthetic generation? Where they're like, oh, halothane, you're using halothane, and like forward, like I'd love to start seeing, I don't know if there is literature I need to look on, like RSIs with rock, high dose rock with that 1.2 milligrams per kilogram, and how many providers are using that, and is it safe? Because it's not standard of care right now, but maybe in the future, based on, literature going forward, it will become that. I do have a note here about patients before we move on to like the alternatives, about prepping the anesthesia gas machine. So essentially you flush the anesthesia gas. So you have to have a gas machine in the operating room. That's what's safe to provide any anesthetic, even if you're doing a MAC anesthetic, which we'll talk about are some of the alternatives. So in terms of the anesthesia gas machine, you would flush out the system, right, with high fresh gas flows. So that's 10 liters per minute at least, for 20 to 60 minutes, depending on the model of the anesthesia gas machine. Just mentioning this for boards purposes, because I feel like it's important and practice to know this. And a lot of the majority of our anesthesia techs know this as well, because it's part of their job to help us do this. Or placing the activated charcoal filters in order to provide anesthesia with that machine. Obviously not the anesthesia gases, but oxygen, nitrous oxide, like you had mentioned. And I love that differentiation, because I think students get confused that all that nitrous oxide is a volatile agent, and it is not. My students should be nodding and knowing that that is not the case, that it is separate and it is okay to give to MH susceptible patients. So I just wanted to quickly mention that. But can you guys talk a little bit about what are some of these safer alternatives for these patients in terms of the anesthetic plan?
Yeah, for sure. And one thing I wanted to mention too, when you're prepping your machine, we all have our different preferences. My preference is I take the vaporizers completely off the machine. I know some people will like put tape over them, or they'll do something so that, because we're all creatures of habit. Like you'll intubate the patient and you just instinctively go to turn on gas, or you are used to just going through your normal flow of things. You need to do something, whether it's locked or whether you take them off or you tape it. Like you need to do something that makes it so it's very, very clear that you're not using gas. Maybe someone comes in and gives you a break, but there's just levels that you can go to again, just make sure that you're not accidentally doing those things. I had one where I had an MH case, like it was known, and so I had taken the vaporizers off. We have anesthesia techs at our facility, and you mentioned they're very well versed in like knowing how to take things off and kind of go through the whole flow, flush, and all that stuff. I finished the case. I went home. The next day, somebody like ran into my room as I'm getting my case started, and they're like, "Patient's asleep in OR 6 or whatever. There's no vaporizers on the machine." And I was like, "Oh, well, use some nitrous." And they were like, "Where are the vaporizers?" I'm like, "I have no idea where the vaporizers are." Like, anesthesia tech took them off, and they took them somewhere. Obviously, did not put them back on. But I remember that nurse just like looked like pure panic, like the patient was going to come off the table. I'm like, you can push propofol, you can run nitrous, like it's going to be okay, we're going to figure it out. But
it's just going to be a TIVA. It's going to be a TIVA.
Like yeah, exactly. It was sitting on the sink right outside, the perfect place for it, outside the OR. So just keep that in the back of your mind. If you do take off the things from your machine, put them back on for the next person. They'll thank you for it. But let's get to what you asked.
I think too, Tanner, though, like that's why I think everybody's so scared to use nitrous oxide, is that we're so scared to even touch anything on the anesthesia machine because we're afraid to give anything that might cause it. And so it's just easier to be like, I'm going to hang propofol and just do a total intravenous anesthetic rather than even mess with that. But no, it is, as long as you flushed it out appropriately and cleared everything from the circuit that might have residue of the volatile anesthetic, you can give the nitrous. There's nothing wrong with giving it. But I think that's why we're so scared, because we have all this tape across it, don't use, don't touch, and we're just nervous to even breach that area of the anesthesia machine.
Yeah, for sure. So what does it look like? What can we actually give these patients? So we already mentioned this, the TIVA, total IV anesthetic. So that's going to be fine. We can use propofol, ketamine, whatever else you want to use to sedate these patients. Regional anesthesia is going to be really nice for this. I would argue it's nice all the time, but especially with these patients, you're going to want to try to pull your weight with using regional techniques to try to mitigate whatever you might be lacking in getting away from using your volatile anesthetics. Non-depolarizing neuromuscular blockers, I think that there's some correlation in my mind of knowing that people are at risk for anaphylaxis with like rock and sucks, and that I think in my head there's like some correlation where I think MH, rock, I know it sucks and the volatile anesthetics, but there's like some correlation that goes in my mind where I think, oh, is rock okay for MH? It's totally okay. We're not having any issues here. And that's just like a weird connection that happens in my brain. But I always like second guess myself when I have that MH patient. I'm like, okay, yeah, non-depolarizers are totally fine. We've already mentioned this, but nitrous oxide is going to be totally fine. Opioids, benzos, acidosis, all totally fine. Really, the list is very small. If you're into memorizing, which we've already told you, don't be into memorizing. But if you're into memorizing, SIVO, DES, ISO, sucks. It's all you got to care about. Everything else, you're going to be good.
That you mentioned questioning rock, because that's just what we do. We don't see this every day. And when we do have an MH susceptible patient, we run through the checklist in our heads. And like you said, you don't have to memorize it per se, but you get to a point where you just know it and you know what you can and can't give. And I think nitrous oxide is the kind of the confusing one. And then our non-depolarizers, because again, like Cole had mentioned, we just don't want to touch anything that could potentially, cause this. So those are really important differentiations to make. Okay, so let's move kind of towards, like, we've recognized MH, and this is a huge boards thing. What do we do now? Like, we've decided that it's MH. Can you kind of walk through the steps in terms of what we do now?
Yeah, 100%. So, I mean, the easy part is recognizing what it is. The hard part is, well, how do you stop it now? Like, what do I need to do in this moment where your emotions, if you're the CRNA in the room, your emotions are now high, especially if this is a pediatric patient, which is primarily when it happens, because typically if it's going to happen, it'll be in their first anesthetic. So it's going to be in the pediatric world. I don't know, emotions, at least for me, when I'm taking care of a pediatric patient, are higher. And if something like this happens, you have to initially calm your own sympathetic system down and think logically. How am I now going to approach this and actually stop this from happening? The first thing, which should be obvious, is stop the trigger immediately. So if the succinylcholine is the trigger, well, you're probably not still pushing succinylcholine. You've already given that. But really, it's the vital anesthetic. If you're still running your vital anesthetic, you better turn that thing off right away. But that's not it. Don't just simply turn the gas off. You really need to be switching your oxygen circuit that's attached to that would have any residue in it. So this would be switching for 1 to 100% oxygen at a high flow. But I would even recommend you bring an actual oxygen tank separately that you're running, maybe an ambu bag or something like that you connect, because you don't want to just switch to 100% oxygen and now you're still flushing residue from the anesthetic gas through. But at the bare minimum, turn off that gas and just run 100% oxygen through your circuit. Step 2 would be, now we got to start figuring out how do we minimize the damage and band-aid some of the side effects that are happening because of this. And so the first is going to be, let's start hyperventilating the patient. So we're giving 100% oxygen, but now let's start hyperventilating to get that end-tidal CO2 down, because remember, that's going to be the first thing that we see. And so hopefully you've caught this early enough where that's one of the only things that you're seeing, and you can start to minimize that. But usually more things have started to happen for you to come to this diagnosis. So you're going to start hyperventilating, bringing that end-tidal CO2 back down. Obviously, you want to call for help. So this is where it's helpful if you know your all anesthesia help number, or you just yell out for the circulating staff, hey, I need anesthesia help in here stat, while you're doing the things that you need to do. But you want to call for help, get back up in there, and you want to activate. Most facilities will have an MH cart or MH protocol that's going to be in place where you say, hey, I need the MH cart. And they're going to get that, bring it in, which is going to contain the main treatment that we need, and that's a medication called Dantrolene. And this is something that we don't give unless this situation happens. And so a lot of people are just unfamiliar with how the process works. It's not simply you get a medication in the room like Lasix and you just draw it up and push it. You have to reconstitute Dantrolene. This is several people working together to do this. It's not just a quick, easy ANSEF reconstitution and you push it. It takes some time. And you give this dose at 2.5 milligrams per kilogram IV rapidly as a bolus. And then you repeat this every 5 to 10 minutes up to 10 milligrams per kilogram if you need that much. Thankfully, we now have another option that we can do for this called Ryanodex, which is much easier to give. You don't have to spend all the time reconstituting it. Thankfully, like I said, I haven't had to reconstitute it. Chloe, did you have to do Dantrolene when you had your situation?
We did Ryanodex, which so the providers actually started mixing it with 60 mLs of sterile water because that's just what they remembered from school. And so we did a re-education on Ryanodex and what it is, because it wasn't available even when I graduated 9 years ago. So much faster.
Yeah, much, much faster. So be thankful now that we have this, because the only time I've had to do it is in clinical from school, or simulation from school. But even then, it's just on top of everything going on, it just takes a lot of time. So you give the Ryanodex, which is much faster, but again, your dose is 2.5 milligrams per kilogram IV rapidly. And then also we're going to treat the hyperkalemia and acidosis that is developed at this point. So the thing that you're concerned the most about with hyperkalemia is you don't want to cause arrhythmias to happen from a cardiac standpoint. And so you need to stabilize the cardiac membranes. And so you're going to give calcium chloride to do that. And again, that's not going to help with the potassium, but it just helps stabilize the cardiac system. Then you're going to give medications to lower the potassium in the plasma. So we'll give bicarbonate, which will help with the acidosis that's occurring because of all this anaerobic process. You're going to give insulin and glucose to lower the kalemia levels. And again, you're going to hyperventilate as well to bring that back down from an acid-base standpoint. And then you're going to cool the patient. So again, I always remember this. Increased temperature is one of the last things to happen. I'm also going to treat that last. I'm going to do the other things first that are more pertinent. And then now I'm going to get ice packs, cold IV fluids. You can do gastric, bladder, or rectal lavage to cool those systems, especially if they're severe. If they're potentially seizure level high, then you're going to really want to decrease this sooner than later. But again, hopefully you've caught this before they've gotten to that point. And then last, you're going to monitor their urine output. Again, this is just simply from all that myoglobin in the urine. You just want to try to avoid renal failure with this. So you want to consider giving mannitol, Lasix, just to continue to flush all of that out and keep the urine flowing. So we avoid some renal failure that could result from that. But again, biggest thing, if you remember anything out of this, Dantrolene. Like, that is what you need to do to stop this. You stop the triggering event, give that Dantrolene, but you're also then treating all the signs and symptoms that occurred because of the problem.
Yeah, I love that. So Dantrolene decreases the calcium release from the sarcoplasmic reticulum, stopping it at that molecular level and curing, quote unquote, the symptoms of MH and getting us to a better state. I will say that for all the CRNAs listening, that like I said, Ryanodex is new. So if you aren't familiar with it, it's 250 milligrams per 5 mLs. So the concentration is the same as old school. We'll call it old school Dantrolene. So when I said that the providers mixed it with 60 mLs or 50 mLs of the sterile water, the concentration was the same. So everyone was confused. And that's why these pharmaceutical companies do these things where they make sure that the concentration is still the same so that if you mix it based on old rhetoric or old literature rather, that the concentration still, the patient's still going to get the same amount. It's just going to take much longer. And that's the whole point of Ryanodex, is that it's so concentrated. And when I say we started to see the symptoms resolve within the hour that we were in the operating room, it was that instantaneous. I mean, everything started to correct. The hypercarbia, which I think the patient's end-tidal CO2 was like in the 70s, getting close to 80s, and then it slowly started trending down, temperature as well. It was pretty amazing to see, to give it that quickly, which is the benefit of Ryanodex. And we know it's not available everywhere, like Sugamadex isn't available anywhere. I guess it's bougie where I work and they had it. But for the CRNAs in the chat that are listening, there is an update on even Dantrolene versus Ryanodex, which is awesome. Now we can kind of go into the postoperative care. Okay, so now we've identified that it's that back shelf MH. We've given the Dantrolene that fixes the calcium release from the SR. So now what? What do we do postoperatively? What should our learners be thinking in terms of a postoperative care plan?
So these patients, we're going to take them to the ICU. They're not going to, go to PACU. They're definitely not going to go home. They're going to the ICU for continued medications and also just monitoring, because you can see recurrence of this within that first 24 hours. And so you want to be watching very carefully for these patients to be monitoring that this doesn't happen again. They're going to continue the Dantrolene 1 milligram per kilogram for 4 to 6 hours. So that's going to be a continuous infusion that you'll give the patient. And then we're going to be wanting to monitor labs. So we're going to be monitoring creatinine kinase, potassium, coags, ABGs, myoglobin levels. These are all things, again, I keep coming back to like understanding structure, but these are not new things. Like these are the things that we have seen in the crisis moment, and these are things that we're going to continue to monitor after. So this isn't a whole new list that you need to be thinking about. These are the things that we're concerned about with the potassium shifts. We're concerned about with monitoring our ABGs, to be watching our CO2 and monitoring our myoglobin levels. So these are all monitoring our kidneys. These are all things that we saw in crisis. Now we need to keep monitoring postoperatively as well. And so continuing that Dantrolene, again, it's important to, this is something I didn't understand at the beginning, is that this can occur again. This is not something that, okay, we've given the Dantrolene, wash our hands, move on out of here. It feels like that because it's so effective at fixing the ryanodine receptor that you think, okay, we solved it, it's good, but you can see this recurrence. So it's important to be very vigilant when you're monitoring these patients after the surgery. We want to maintain large urine output. That's primarily to protect the kidneys. You want to treat that hyperkalemia aggressively. Again, like Cole mentioned, we don't want to be getting into any cardiac issues. And so we're going to be monitoring potassium and trying to adjust that to keep the patient safe. And then a huge part that we need to think about is how do we talk to these patients? Like this is something that is obviously a huge event for the patient, for the family, something that it's not like, everybody comes home from getting their gallbladder surgery and they're like, oh man, made it through the MH this time. This is like, this is not a very common thing. Like we talked about, we've seen it twice sort of in all of our careers. And this is something that is really, really important. They understand the severity of it, how catastrophic it can be, and that they need to understand that this is not just something that they have. This is genetic. This could also be related to other family members. They might tell you, like we talked about at the top of the episode, well, so-and-so's had surgery, never had any issues. That doesn't mean they don't still carry the gene. And so referring to get MH testing for genetic evaluations can be really important to make sure that they can safely have all the information they need when they're going to get another anesthetic or another surgery. So of course, we're always thinking about the patient and kind of just like the physical aspect, but we need to also make sure that education is crystal clear for these patients to understand the severity and then also understanding their risk factors and who that applies to in terms of their family.
Yeah, I love that. My sister had a friend. We were all hanging out. And this was like years ago. I must have been in anesthesia school, actually. And my mom's a CRNA. She's been a CRNA over 20 years. So we have that kinship. But this friend was we were talking about surgeries and anesthesia probably, because what else do we talk about when we're together? It's like freaking anesthesia all the time. And they were like, oh, my mom got really hot when she had anesthesia, so I can't have like regular anesthesia. My mom and I like both looked at each other and we were like, how rare, but also like what he was advocating for himself already at that young age. I think he was like a teenager at that point. And so, yeah, it's really important to educate our patients so they can be an advocate for themselves, but also their family, right? Because it is that genetic piece that we need to know as clinicians in order to provide safe anesthesia care. So I always think of him because, like, how rare is that? And he was just like, yeah, my mom got really hot. My mom and I were like, what the heck?
Yeah. Tell us more.
Yeah, exactly.
That's crazy.
So to wrap this all up, I love how Cole, and I want to mention this because we're going to go into the fluffy part of this podcast, I call it. I like how you mentioned about calming your own SNS system in a crisis. And crisis management is like an emotional intelligence or like things that I'm really passionate about, and OB practice. Those are my 3 tiers. And Presidex. Okay, anyways, I have a lot of tiers. But when it comes to crisis management, you've all seen scenarios, you've walked in and it is chaos. And in the flip side, we've seen scenarios where everyone is calm, knowledgeable, delegating. You know, I went to a code not that long ago and I complimented the intensivist because I was like, what a great code. He was just with his arms crossed going, anybody have any ideas for H's and T's? Like the way just we set the vibe as anesthesia providers. I tell students clinically, we're at the head and we kind of lead the crisis management scenarios, which is new for ICU nurses going into anesthesia. But we truly set the vibe. So thinking about MH, thinking about crisis scenarios is really important because it helps calm your vibe if you've already thought about the scenarios and what you would do in them. So I hope that this podcast has helped everyone kind of refresh MH, how to identify it, what it actually is in the molecular level, and then how to treat it going forward is really important because then when you're in that scenario, hopefully never, like Cole said, but it could happen. It could happen to any of us any day. So we got to be prepared for it, right? So again, that's like my little piece of advice or encouragement. This is the part where I like to have our guests speak to one piece of advice or encouragement with having to do with MH, not having to do with MH, just to encourage learners in the throes of anesthesia school. Can you guys share a piece of advice for our students?
Yeah, well, piggybacking off of what we were just talking about, when you have situations arise, and both of you talked about the idea of when you come in as a second CRNA, it's totally different than when you're primarily in there because you feel the only thing I can relate it to is you feel the emotional attachment on top of the clinical, the clinical signs and facts that you're seeing from the patient. And for me, especially when I graduated anesthesia school, I wasn't quite prepared for the fact that I guess I assumed when I graduated that I was just 100% ready to take on anything that happened in the OR. And I was so used to having a second pair of hands that were to help me when things arose that I wasn't as prepared to individually figure things out when crises arose. And I struggled at the beginning with, I think I was 2 months out when I had my first patient code on me as an own anesthesia provider. And it was like the end of a lap chole of all things. And the patient was waking up. I already had him spontaneously breathing. Gas was off. And patient up coding 6 times, got him up to the ICU, ended up passing away. But in the moment, I remember I let my emotions and attachment of like, this is my fault. I must have done something wrong. Like, what is happening here? Distract me from the clinical things. And thankfully, I had other people come in and they were helping and they were giving ideas about how to do differential diagnoses. But ever since that moment, I've made it my goal each time that it's normal to have that almost like numbness when something first goes wrong, of that overwhelming sense of almost like fear when something starts to happen to your patient. That's normal to have that. But now my goal each time is to minimize how long that lasts and to snap back into the clinical side of things and what's best for the patient. How do I be the best advocate? But it's understanding that we're all human. Things are going to happen regardless of if you did something that caused it or if it just happens in the operating room. It's going to happen. You're going to have that emotional response. But thankfully, at least most of us work in a facility where you have backup that's able to help you. But if you are somebody that works in an isolating place where you're the only anesthesia provider, it becomes very important to be able to clear your mind from that emotional attachment and start thinking from a logical standpoint on what's step 1, step 2, step 3. And so that's kind of been my goal and my advice to anybody that's starting new is don't beat yourself up if you have those feelings. It's how do you minimize the length that those last when those situations arise.
Yeah, that's really important. And I think I love how you mentioned that last piece where you want to decrease the time that it lasts, because to go into a scenario going, I'm not going to feel that is not an attainable goal. We talk about attainable goals in research a lot, and that's just not an attainable goal. I think that's so smart to start small and just decrease the amount of time. I also do it afterwards and the amount of time that I take it home with me, because I take it home and I will talk about it. I'm a talker, clearly. I'll talk and talk and talk about it, and I obsess over it almost. Like, what could I have done better? And it's what makes us vigilant, good clinicians. But at the same time, for your mental health, you got to kind of reel it in to a certain point. So I think that's a really good attainable goal, is decreasing the amount of time your SNS is kicked up and emotions are kicked up in the scenario, and then afterwards as well. So Tanner, what are your pieces of advice?
So I remember when I was, I'll say my part in two parts, but the first thing, when you're talking about having like a clean code, I remember my first time I was an ICU nurse, and it was my first code as an ICU nurse, and the code alarm rings, everybody's running to that room, and this resident like runs by us all. I literally get in the doorway and I watch him go over and do a precordial thump on this patient. And I have no idea what this is. And I'm like, well, surely like assaulting the patient's not going to help at this point. Like, I have no idea what's going on. This just seems all chaos and wrong. And it was interesting because like I was so new, I was so green, and yet I could sense like it felt out of control. Whatever I was walking into just felt out of control. And I remember when we were debriefing after that code, there was a doc who had been there for forever. And he's like, 3 seconds is not going to make or break like whatever decisions we make. Take 3 seconds to calm yourself, think clearly, evaluate. And you see this all the time. Like, somebody needs anesthesia help in the ICU or in the ER, and it's like, you see the providers that come in calmly and they are just like, they're speaking directly. I need this. I need this. I need you to grab me a stylet. I need you to grab me a syringe. And they're just like very calm and collected. And you also see providers that come in and they're just like barreling through the door and it just feels like chaos. I'll tell you that the 3 seconds that they saved by sprinting through that door is going to be lost in the lack of clarity and direction. And so it's like, I get it. The nerves are high. You're feeling a rush. You're excited. You're nervous, all the things. But if you can find time to just like take 3 seconds before you walk into whatever environment and just say like, I don't need to rush this. I can be very calm, collected, and be very direct in your communication. It's going to be so much better for you in the long term. And it's something I try to practice a lot with when you're, especially being the second hands. Don't add more chaos to the situation. And then piggybacking off of what you were saying, Chloe, something Cole and I talked about on one of our mental health episodes was this idea of like taking the long view. And so for these types of events, the long view exercise goes like this. If it's not going to matter in 3 years, so in 3 years, you're going to be sitting on your back porch, talking with friends, having a bourbon, whatever you're doing. Are you going to be worried about like this event? So like we're talking about MH. This is a big event. Maybe you'll still be thinking about that. If you're missing an intubation on a patient that was a difficult airway, like, are you going to carry this with you? If you're not, then you don't need to carry it home. You don't need to carry it into that evening. You don't need to let it weigh on your mental health for the rest of the day. Like, have good ideas of like, what is future me thinking about? Does this matter to future me? If it doesn't, then you need to just like move on from it. Let it go. Talk to your safe people that you can talk to about, hey, this is what happened today. It was really frustrating. It made me feel really anxious, whatever. Get that talking out and then leave it. Like, we don't need to carry this on. And so I think what you said about going home and always talking about, oh, what could I have done? We all do this, and just trying to have some self-awareness of like, okay, what kind of a problem is this? Is this a big problem? Is this a future problem that I will think about for a long time? Or do I need to give this its moment and then move on with my day? And so that's something that we try to practice. It's hard because of course you want to be perfect and you're always trying to, reevaluate things. But I would encourage you, wherever you are in your anesthesia training, try to take the long view, use that exercise and see if that helps you.
This is going to sound insane, but when you mentioned, in 3 years from now, is this going to matter? I always think, and in the spirit of Christmas for all those who celebrate, we are recording this in December. If you're listening to this throughout the year, this is December. And I always think of the quote from the Christmas song, a year from now, our troubles will be miles away. And that's something I keep with me. It sounds insane, but I keep that with me like year.
At this point, you have to say.
I'm even butchering the quote. I'm like, is that even what it actually says? Like, you trust me, you do not want me to sing it. Maybe my 4-year-old, if she was here, she'd belt it. Yeah. But I think about that. Like, a year from now, a lot of the things we stew on, whether it's anesthesia related or just mental health related, a year from now, we won't even care. And so I really reflect on that as a person and as a clinician. And I love how you mentioned that, because a lot of the things, they seem so big. And then as the weeks go on, they get smaller and smaller and smaller to the point where you're like, why was I even like worried about that? We did the best we could. And again, hindsight is 20/20 and all of those different things. But I think we mentioned so many great things throughout this podcast, academically, clinically, mental health at the end. It's just a well-rounded pod. I appreciate you guys for taking the time out of our busy schedules to be here. And to all of our favorite learners, thank you for listening. Thanks, guys, for being here with me.
Thanks for having us.
Thanks, Chloe.
Stop.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.